Welcome to the VHQC Stopping Sepsis in Long-Term Care conference call. My name is Christine, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. I will now turn the call over to Shiva McLean, Maryland Program Director. You may begin.
Thank you, Christine. And welcome to the Stopping Sepsis in Long-Term Care webinar. Our focus today is making the connection between sepsis, C Diff, readmissions, and mortality. As Christine said, I am Sheila McLean, a Program Director with the HQC, and joining me today are Candy Hamner and Teresa Mandela, both improvement consultants with the HQC, and Candy and Teresa are going to be your guest speakers for today as well. And as part of introductions, I also want to just always recognize our partners that are a key part of our team, and that's Bonnie DePietro with the Maryland Patient Safety Center and Justice Zimbra with the Maryland Hospital Association. So as we get started today, we ask that you be committed to giving us your attention, being engaged, open, collaborative, and actionable. At the end of the presentation today, we will have a Q&A session, and at that time, Christine will provide us directions on how to open your line so that we can take those questions. Or you're welcome as we go through the presentation to put any thoughts or questions that you may have in the chat box, and I'll be monitoring that on our team's behalf today. And then at the very end, we ask that you just take a couple of extra minutes at the end of the presentation and please answer some of our evaluation questions that we'll have posted, because again, we learn from you all and we want to make sure that we're delivering information that is beneficial to you and learn about future topics that you would like to hear more about. So please take a moment and fill that out. So what we're going to cover today between Teresa and Candy are really three parts. We're going to review some of the facts, some of what we've touched on before in our Stopping Sepsis initiative, but are definitely worth repeating and keeping in front of us. Second, we're going to go into some of the mechanics, the physiology behind sepsis, talk more about early recognition, and lastly, Candy will help us take a look at some of the high-risk groups for progression to sepsis. During this entire presentation discussions, like I said, we're open for questions and comments, so feel free to put those into chat, and we will track those. And at the very end, we'll be sharing some next steps with you as well, following what you can do at your facility at the conclusion of the presentation. So at this time, I'm going to turn our program over to Candy.
Thank you. This slide you've seen several times before. It's given to us courtesy of TMS QIO, and it reminds us of some of the scary facts about sepsis. And at this point, I think sepsis is the #1 cause of acute admissions, not only in Maryland, but across the USA from a nursing home. It's the leading cause of readmission across this country. And in Maryland, both C Diff and sepsis top the chart for readmissions. And here's a surprising fact. If you look up here and it says 1 million cases of sepsis occur every year, and yeah, we've seen that before, and that 500 people a day die, which we've seen that one before. But did you know that more Americans die from severe sepsis than from breast cancer, lung cancer, and stroke combined? I was startled when I saw that fact. Next slide. Sepsis appears to be on the increase, and some of that may be attributed to the fact that public awareness of sepsis itself, as well as its symptoms, are not well understood by public. Most laypersons don't really understand that some of these vague symptoms can really lead to sepsis. it's really important that the public become educated. Between 2000 and 2008, the number of sepsis admissions to hospitalization doubled. And a lot of that could be helped if we had better education. In April, we provided you with a brochure and a set of slides that you can use to present sepsis to families, boards, and laypersons. If you haven't used them, please get the slides out and educate your public. Interesting enough, some of these other interesting facts is that pulmonary infections that lead to sepsis appear to have a higher incidence during the winter months. And another surprising fact is that more African American males appear to get sepsis than any other group. Sepsis rates in Maryland and acute care hospitals, the mortality rates have been as high as 30%. The good news is we are on a decline, and we are seeing those mortality rates decrease. Still, sepsis and C Diff, two of the highest readmission rates in Maryland and across the nation. Next slide. Patients over 65 account for close to 60% of the severe sepsis cases. And keeping in mind all that we've just talked about, we need to think about our residents and our nursing homes. They are at risk for nosocomial infections, and we also know that the incidence of C. diff is on the rise, and the virulence of C. diff on the fragile population. So when you think about it, most of your residents in a nursing home are over 65. 60% of the severe cases of sepsis of residents or people over 65. So people over 65 have 13 more times likely to develop sepsis, 2 times more likely to die. And just because they reside in a nursing home, they're at risk. Enteritis and other GI-associated infections, along with the pulmonary infections, when they become septic, that's the highest mortality rate. Next slide. How does sepsis occur? This slide, courtesy of Texas Gulf Coast Network, is a great visual on being able to look how a normal infection becomes uncontrolled. You look over to the left, you see the little drop of water, and that's the local infection. That's the UTI that the patient has that you begin to treat. But what happens is somewhere in this process, a localized infection becomes an uncontrolled inflammatory response that attacks healthy tissue, and that's what you're seeing on the left. To tell you why one patient can have pneumonia and they're fine and they recover, and the next patient gets pneumonia and becomes septic, that's a mystery, I think, to all of us. But what we can do is look at the high level of what happens once sepsis starts. Next slide. This is a simple overview of the pathophysiology. For starters, I think we've talked over and over again, but it's worth repeating, sepsis will not occur without a source of infection. So if a resident has a UTI and the body responds normally to that infection by sending WBCs, white blood cells to that source, that stage the infection is localized. Remember from the preceding slide where we saw the drop of water and then we saw the huge wave? When the infection gets into the bloodstream, it moves quickly throughout the body and goes to remote sites. And the inflammatory response goes to remote sites. And suddenly we have inflammation and edema in tissues and vital organs throughout the body. Next slide. The pooling of fluid in the tissues because of the edema causes blood pressure to drop. Oxygen can't get to vital tissues, and that creates a whole set of issues. The inflammatory response results in blood vessels becoming what they call leaky, and more fluid goes out into the body, which causes the blood pressure to drop more. The body responds to this by sending coagulation factors out. The problem with that is you get clots forming in vital organs and tissues, and then once we run out of that ability to send coagulation factors, we flip to the other side and have what you all are familiar with, DIC, disseminated into that, where coagulation occurs, and then you have bleeding everywhere. There's been a lot of change in sepsis. There's been a lot of focus on sepsis in the last year or two. But since February, there have been a lot of changes in definitions and terms. One of the things that you're going to see in the literature is sepsis is now defined as a life-threatening organ dysfunction caused by a dysregulated host response to an infection. In everyday terms, sepsis is a life-threatening condition that arises when the body's own response to an infection causes tissue damage and injury, and it's actually the body's response that causes the infection. Next slide. So what about sepsis in our residents? Sepsis in our residents, there's 4 different groups that you think about, and these are skin and soft tissue infections, respiratory, pulmonary infections, urinary tract infections, and enteritis. And what you want to think about are whether or not your residents with catheters, IV lines, central lines, and tips. These people have areas where an infection can start. Think about wounds, wound vacs, G-tubes, are all potential candidates for infection. Residents who have an infection, though, ones that have pneumonia, a UTI, or C Diff, they are at a higher risk because they already have an infection that needs to be addressed. Keep in mind, every hour a resident who has sepsis waits for treatment, the likelihood of death increases by 8%. And I know we've talked about that before, but it's something that you need to really think about, because time is one of the most important things when you're treating an infection. Next slide. This is a chart courtesy of Texas Gulf Coast Sepsis Network, and it's a really nice one to look at. It's geared towards acute care, but I think there's something we can benefit out of it. And if you look at this continuum, you have the clinical signs when they first start, and what you're going to see in your nursing home: tachycardia, tachypnea, confusion, fever, and then the nurse's response, what the nurse needs to do. What this, to me, says, if you need to have that 100, 100, 100 screen into one place, you need your GNAs, your staff out on the floor, conscious and aware, so that that nurse can come in and do that assessment. Next slide. This slide I put in just, and again, courtesy of TMS 2IO, it's a nice visual for you to see all the different organs and areas that are impacted by sepsis. And it's amazing that that infection that somebody might have from their pressure wound affects the respiratory system, the metabolic system, the cardiovascular, your kidneys, your bloodstream. Everything is impacted by the severe sepsis. And this is why the whole time piece is so critical. Next slide. So, time is tissue, and I think that's something you really, really want to think about. And I'm going to read to you. I know you don't like me to read to you, but I'm going to read to you because it's worth repeating. Early recognition of the potential for sepsis is vital in the nursing home environment. We need to identify who has the potential so we can be more vigilant to what's happening with their symptoms. Identifying the residents who are more susceptible is also key in recognizing early signs and symptoms. And then once you identify something to look at, timely assessment and treatment is critical to survival. So think of it. Recognition, intervention equals survival. Next slide. This is another graph that was given to us or shared with us from a TMS 2IO, and this just shows the critical connection between antibiotic timing and the potential for mortality. And the quicker the patient, resident, gets that antibiotic, the higher the percentage for survival. So, go to the next slide. I had mentioned to you earlier that a lot of the definitions for sepsis have changed, and there's a new definitions that were just released in February of this year, and what they look at is sepsis is an infection suspected or confirmed. And that's an important thing for you to think about. If you have a resident who has a Foley in, they've got cloudy urine, they're complaining of burning, and they also have some mentation, their blood pressure is below 100, the respiratory rate's up, the fever, then you have somebody who potentially is heading for sepsis. And that's the resident you want to intercede with. The other new definition they have out, they've eliminated severe sepsis, the septic shock, which requires you to have sepsis, plus one of the things that you have, the hypertension, this is now a resident who requires vasopressors to keep their blood pressure up, and that despite giving them a bolus of IV fluids, they have a serum lactate of 2 millimoles a liter or higher. Next slide. So now let's talk about our residents at risk. And I think hopefully from what we've gone over, you have a good idea of what we have to be looking for and how quickly we have to act. Residents at risk for sepsis progression. And what I'm talking about is someone who's got something and they're at risk to become septic. And it was the pressure wounds, the diabetic wounds, the skin infections, people that have drains in, G2. Think of that whole group. It's somebody who can potentially get an infection that will be localized that could become that big wave that we saw earlier. End-stage COPD, vented patients, all the respiratory illnesses that can happen, and including your residents who have flu, cold, and bronchitis. Think about the urinary tract. It's not just people have UTIs. When you do a device change, you can introduce an organism that can have the resident become septic. And also, many residents have obstructive stone disease or urinary retention, which creates an environment where sepsis can occur. C Diff, enteritis, invasive colitis. These are all areas and concerns, and any resident that has a weakened immune system is somebody we need to think about. Next slide. These are just some other risk factors that I picked up from the literature. And one thing that's important is if you have a resident who gets admitted from an acute hospital and they were septic in the acute hospital, I don't remember the exact number, but it is a huge increase in their potential for them to become septic again. Anybody who's malnourished, your dialysis patients, an unbelievable number of dialysis patients become septic. And, of course, anybody that's had radiation, chemotherapy, a recent procedure is at risk. Next slide. So I know that was a broad group of risks, and you think, well, that's everybody that's in the nursing home, and it probably is pretty close. So we need to focus in sometimes on where are some of our biggest worries. And two things I think is important to think about. Urinary tract is the most common source of a nosocomial infection, and it can lead to sepsis. And it's probably one of the most common, urosepsis, one of the most common. So that really says to you that's an area of residence you want to look at. The fact that gastrointestinal and pulmonary sources have the highest mortality rate is something you really need to consider. And the fact that C Diff has seen a marked increase in nursing homes over the last 15 years, and it's become a high risk for sepsis and septic shock, is something I think we all need to think about as far as looking at our residents. Next slide. So let's focus on early recognition is equal to survival. So all residents in long-term care facility are at increased risk due to their age, their comorbid conditions, and the potential for the spread of nosocomial infections. So where do we start? We start with education, and that's educating your staff. You want to start with teaching them that time is tissue. One of the most important things in saving a resident's life is not waiting to see if they're going to get better. It's taking action when you notice these symptoms. You want to make sure that you are using the Seeing Sepsis 100 tool and that your nurses are educated on how to screen for possible sepsis. And if you haven't done that, you need to do that right away. Next slide. The next thing you need to do is implement, can we go back one slide, please? Thank you. We want to implement and follow and monitor good infection control practices. You need to assess your infection control policies and procedures. Assessing them, though, isn't enough. You have to look to see, are you really following them? And hand washing. Hand washing is probably the single most effective way to stop the spread of infection, and it's one of the best ways to prevent C Diff. You know, yes, lots of residents get C Diff from antibiotics, and we have to think about and practice antibiotic stewardship. But we also spread C Diff from resident to resident because we're not following good infection control practices. So repeat, follow, and monitor hand washing, and then make sure people follow sterile techniques for those dressings. And that includes the PICC line dressings, that's the dressings around the G-tube. You want to prevent those residents from getting an infection. And one of the simple things, vaccinate. Vaccinate your residents. Give them pneumonia vaccine, give the flu vaccine. Prevent those two opportunities from ever happening. And again, practice antibiotic stewardship. It's a tight line. We have to make sure we're not overusing antibiotics, but we need to make sure we are using the appropriate antibiotics at the person's time. Next slide. Okay, I've said in the past that the 100 tool is one of my favorites. I think this is my next favorite. And this is make changes in mental status, a hard stop, requiring you to think. Think about why is this resident had a change in mental status? This is they're telling us something's wrong. So you want to make sure you check those vital signs, the pulse, the blood pressure, the respiratory rate, the temperature. And if they have a mental status change and these signs and symptoms are positive, then you want to have a nurse assessment. You want the nurse to, of course, verify the vital signs and identify the possible source of infection. But that mental status change, that's a hard stop to say what's happening with the resident. Next slide. I put these two in here. You've seen these before. I just want to make sure everyone has access. These are the Seeing Sepsis 100 pocket cards. They were put in your, they're online. You've had them in 2 or 3 presentations, but I want to make sure that you know that you have them. If you have any problems getting them, please let us know. Next slide. This is the Seeing Sepsis 100 access poster. Again, you've had this introduced to you many times. Just a reminder, you've got the 100 tool on the right, and on the left, you've got the nursing assessment. And one of the key things in that nursing assessment is you need to know what the resident's wishes are, because we have to make sure we act fast. We don't want to waste time trying to figure out what the resident's wishes are. We need to make sure that we know those. Next slide. Identify residents at risk for sepsis. One of the things you need to do is think about the concept of high-risk rounds. At our May office hours, Glade Valley presented the concept of high-risk rounds. They shared their rounding tool and their process. These next few slides are going to provide you with an example of how to do high-risk rounding. There's other ways to do it. Look at what works best for your institution. But ideally, you want to round every shift. It's the DON, it could be the supervisor, the unit leader, and you want to have a list of the residents on that unit and prioritize them by their risk. But it's not just prioritizing them by their risk, it's understanding what you need to monitor for each resident. Focus on monitoring and observation that's particular to that resident. For example, the UTI, the obstructive stones. Look at the color of the urine, the odor, the volume, the resident's pain, change in mental status. Next slide. What about residents with respiratory issues? You want to monitor that particular resident. Productive cough. Sputum results if they get sent out. Looking for fever. Looking for decreased urine output or confusion. The residents with skin infections. You're observing that infection. Is it not improving? Is there any drainage? Is there any inflammation or swelling, fever, and of course, change in mental status? The resident that has enteric issues, a C Diff. You're monitoring for an increased volume and frequency of stools. You're looking at hypertension, increased respiratory rate. You also need to check for that antibiotic resistance. Make sure they're on the correct antibiotic. And again, that alters mental status. Next slide. Remember, and I know I just said this a few slides earlier, changes in medication are residents fleeing for a second look. Why is there a change in condition? What can it be attributed to? Think 100, 100, 100. Systolic blood pressure under 100, respiratory rate greater than 22, temperature above 100 or below 96.8, health over 100. Then ask, is there a possible source of infection? And what are the residents' wishes? Next slide. Think quickly. Time is tissue. If you think sepsis could be brewing, you want to contact the provider. If you have the capability and the resident's wishes for treatment, start the treatment in your facility. If you can, while you're waiting for a transfer, if you get the IV going, you get the fluids started, you get some cultures, serum lactate, antibiotics, any of that you can do within your facility's capabilities, and of course with a provider order, can give your resident an opportunity, increased opportunities for survival. Next slide. What's the treating within the facility? And it's consistent with the resident's wishes. You want to obtain IV access. You want to get appropriate cultures right away. Start your antibiotics. Get your serum lactate. Make sure they're getting IV fluids. And again, all of this by provider order, as well as monitoring their vital signs and providing comfort measures if the resident wishes have said they want comfort measures. Next slide. Okay. So in summary of everything we've gone over, and how do you connect all of these pieces together? Early recognition increases your chance of survival. Practicing solid infection control will help reduce infections, especially healthcare-acquired infections. Reducing healthcare-acquired infections will help to reduce C Diff. Reducing hospital-acquired or healthcare-acquired infections and C Diff will reduce readmissions and it's going to reduce sepsis. Reducing sepsis helps to reduce readmissions, and it helps to reduce mortality. It's all a big circle, and it all comes together. And it all starts with us practicing really good, solid infection control. Thank you very much for your time. We are going to put the Q&A off until the very end, as Mel said earlier, and I'm going to introduce Teresa here now to talk about CDI.
Thank you, Candy. That was great. So just to kind of give you a quick overview for C Diff, I know many of you are already members of the VHQC Nursing Home Improvement Network, and now we have 114 facilities here in Maryland that are members. And like American Express, being a member has its privileges. So remember, for every initiative, you have access to guidance from VHQC's long-term care team and faculty experts. And we're always pleased to give you that education, best practices, things like QAPI tools, and a data-driven approach to support your facility. Additionally, our goals are aligned very well with Maryland Medicaid's P4P, or Pay for Performance program. Next slide. As members of the Nursing Home Improvement Network, you have additional opportunities to work on specific projects that are of special interest to Marylanders. You're on the webinar today because you're already taking part in the Stopping Sepsis initiative, and that has a very big impact on your residents. There's a new project for nursing homes centered on C Diff, and this one is designed to engage your designated infection prevention nurse. The Prevent C Diff in Nursing Homes Collaborative begins now. We're recruiting nursing homes to work on antibiotic stewardship, infectious disease communication during care transitions, and tracking, surveillance, and reporting of C. diff. So remember, this is going to be your opportunity to make a difference. Already, the Maryland Hospital Association, Department of Health and Mental Hygiene, the Maryland Patient Safety Center, APEC Delmarva, and other stakeholders are on board and encouraging strong nursing home participation. I'd also like to thank Dr. Paul Mulhausen and the Telegen QIN-QIO team for their C. diff prevention work out in Iowa that inspired some of our slides today. Next slide, please. So what is C. diff? We're just going to cover this really quickly because there's some abbreviations you need to know about. C period little case diff is the abbreviation for Clostridium difficile, and you'll often hear epidemiologists and infection preventionists call it CDI, which stands for C. diff infection. And since early medical microbiology in the late 19th century, culturing bacterial viruses was the standard method used to diagnose infections. But people don't realize the initial human case of C. diff was in 1977, and they were placing stool filtrates onto tissue culture cells in hopes of detecting either the virus or the bacteria. But what was later understood is that the C. diff symptoms were due to two specific cytotoxins called A and B, produced by an anaerobic gram-positive bacteria called Clostridium difficile. And these two toxins bind to the large intestinal wall, causing a pseudomembranous colitis, which is marked by very painful diarrhea and inflammation. And a special note today is that C. diff now is much stronger and more difficult to treat than the cases we saw in the 80s and 90s. It's actually 20 times stronger than cases we saw even back in 1995. Next slide, please. So why should you care about C. diff? Well, I'll tell you, I'm truly putting out a call to action to everybody on this webinar today and the greater long-term care community, because by the time we're done reviewing the next few slides, I hope to have convinced you we need to get to work. Maryland's story is interesting, but it's not that uncommon. We have a higher rate of confirmed laboratory-identified cases of C. diff here than the rest of the nation. And we're wondering why. Is it the chicken farms? Is it the Chesapeake Bay? Is it the fact we haven't had a World Series champion since 1983? I'm not sure what the answer is, but I can tell you, unlike our neighboring state of Virginia, we here in Maryland saw a significant increase in the number of C. diff infections between 2013 and 2014. Last year, in 2015, we had 13 Maryland hospitals with higher C. diff infection rates compared to the nation. And those patients turn into your post-acute residents. But there's more. Keep in mind that half of the patients with C. diff infection show their first symptoms in the nursing home. So this isn't just a hospital problem anymore. It's now a community issue. On top of that, you may recall that the newly proposed federal regs will require facilities to have a system in place for preventing, identifying, reporting, investigating, and controlling infections and communicable diseases. The HQC's new C. diff collaborative helps you meet that requirement by working with your designated infection preventionist and using the tools and resources at no charge. And remember, C. diff does qualify as a nursing home QAPI project. Next slide. Well, there's no surprise here on this slide for those of you who monitor readmissions. You may not care for a lot of C. diff residents all at once, but the ones you do have during the year often tend to head back to the hospital. And what we know is this. 35% or approximately one-third of patients in the hospital who have a current diagnosis of C. diff are sent to the nursing home. 66% of nursing home residents who developed C. diff while in the hospital were recently discharged from the hospital. 26%, or approximately a quarter of nursing home residents who have a diagnosis of C. diff, whether that diagnosis was present on admission or those who developed symptoms while they were in the SNF, those 26% go to the hospital and are admitted. So in thinking about that, just from a business model perspective, it makes sense for us to take action against C. diff because it has the potential to improve our bottom line as well as the health of residents. And isn't our goal to treat and keep residents in our post-acute care setting and then the community if possible? So why are we having to send quite a few C. diff residents back to the hospital? Next slide, please. It's because of the deadly symptoms that we have trouble managing in long-term care. According to the CDC, 1 in 11 people aged 65 and older died within a month of a C. diff infection diagnosis. And sadly, when you look at C. diff deaths overall, 80% of the deaths occurred in folks over 65. Not in folks over 85, in folks over 65. So to us, that's not particularly old. When you combine fever with watery diarrhea in copious amounts and add in nausea, loss of appetite, terrible abdominal pain with cramping, you're suddenly looking at a very sick, very sad resident in agony. This is an awful way to die, and it's an awful way for family members and staff to watch someone die. And remember, you're not even holding them comfortably to ease them through all this because you're gowned and gloved with the smell of bleach hanging in the air. And then there are the cost of the meds alone. In March of this year, the Agency for Healthcare Research and Quality reviewed studies and found that Flagyl, a relatively inexpensive drug, should not be the standard choice for C. diff because it doesn't work and C. diff usually comes back. The recommended drugs now are oral vancomycin at around $2,400 per episode or Difficid at $4,100 per treatment course. So if that C. diff resident comes to you and develops C. diff during their Med A stay, your budget may have just blown up for that month on the med costs alone. Next slide, please. And as bad as it is for one resident who comes down with C. diff in your building, your other residents, the staff, and family members are now also at risk unless you have really strong prevention and treatment protocols in place, just like Candy was stating. Remember, C. diff is hiding in the feces of a resident who has C. diff, and that tiny spore, which cannot possibly be seen by the naked eye, jumps on anything touched by the feces. And we're talking about loose stools in a home-like environment with the nice furniture and the pretty fabrics all around, and you can kind of see where that's going. One of the important aspects of our VHQC's new C. diff prevention collaborative will be educating your infection prevention nurse and staff on recognizing specific symptoms so that residents can be spotted very early on. Additionally, housekeeping and environmental staff become very important players in keeping C. diff from spreading. Next slide, please. So what is going on here? Back in the 80s and early 90s, C. diff was a relatively rare event. People who have other illnesses requiring prolonged use of antibiotics are now at the greatest risk for C. diff, and the elderly, our population, in the nursing homes, are the most likely to succumb. These are the people we take care of, and it's not just a little misery and diarrhea for a few weeks, it's a fatal infection, and it's preventable. We're up to 500,000 known cases per year and 15,000 deaths per year. Worse yet, once you think you've beaten it, C. diff comes back at least once out of every 5 patients, which is really high. Our residents who have been on antibiotics recently are far more likely to contract it. Remember, antibiotics kill the normal intestinal flora that serves as protection against C. diff. And it's the fluoroquinolones, think Cipro, Levaquin, Avalox. Those are the antibiotics having a much higher chance of causing C. diff infections. But all antibiotics pose some risk. And the newest culprits on the scene in the cause of C. diff are the proton pump inhibitors, things like Prilosec, Nexium, Prevacid, Omeprazole. And every nursing home has literally hundreds of those pills in the med cart. They're causing what's considered an add-on effect to disrupt the intestinal flora. Up until about 2000, we were pretty confident we could treat C. diff effectively, and then out of the blue, something kind of frightening happened. A hypervirulent strain emerged, and since then, in 2001, C. diff has been firmly rooted in hospitals and nursing homes. Next slide, please. Here's a sneaky little fact about C. diff. It hangs around for about 5 months on surfaces. These are the same surfaces that we had on the other slide: wheelchair arms, bathroom grab bars, carpeting, you name it. Surveyors have cited FTAG 441, infection control, in cases where feces have soiled carpeting in a resident's room when the resident has a positive case of C. diff. We've all seen it. Worse yet, there are documented instances where well-meaning nursing staff, wearing their own personal protective equipment, have cleaned those spots from the carpet in the room up with towels, and then they put them in the regular laundry, in the rolling basket, out in the hall, where everybody rolls by in their wheelchair and touches the laundry cart, and you know, dun, 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 that's how it spreads. Scrubbing surfaces with detergent or alcohol or vinegar or hand gel will not kill the spores. Chlorine, as in bleach, is the only effective sporicidal that can disinfect C. diff. Next slide, please. And you know that really expensive product your environmental supply company sold you that works with your big extractor machine to clean the carpets? It likely doesn't work for C. diff. And again, that's because only sporicidal disinfectants like bleach are capable of eradicating C. diff. And carpeting and upholstery don't like bleach very much. I put a website link on this slide that does list the EPA-approved disinfectants with sporicidal claims so that your environmental manager can have that list. During nursing home inspections, surveyors have been known to ask to see the product used to clean C. diff from hard and upholstered surfaces, so it's wise to be prepared. Next slide, please. So let's talk about how to approach C. diff because we don't have a good handle on it at all yet. Telling everybody to work on your C. diff infections without giving them data or a plan really isn't helpful. So DHQC is beginning the Nursing Home C. diff Prevention Collaborative right now, and we want you to be secure in the knowledge you're doing everything possible to prevent outbreaks. It makes good clinical and financial sense. Through tracking and reporting in hospitals, we have an idea how much C. diff may be out there. And we know that certain practices related to antibiotic prescribing cause the rates to spike in certain hospitals. But nursing home data and strategies for nursing homes has been kind of hard to come by. So joining our collaborative will help you be very proactive and answer lots of questions like, how am I doing with C. diff compared to nursing homes across the state and across the nation? Because right now we don't have that information. Additionally, from the HQC, you'll gain support in things like antibiotic stewardship principles and best practices, the latest C. diff management strategies, and this next one is a big one, coaching for your infection prevention nurse on tracking, reporting, and using reports for measurable improvement, improving infectious disease assessments and communicating them properly during transitions of care, and lastly, access to one-to-one consultation with infection prevention experts here at DHQC to tailor your program to your unique needs. Next slide, please. So here's exactly what you can do to make a difference. Take your infection prevention nurses' skills to the next level and get your team in shape. When you join the collaborative, we're going to work directly with you and your designated infection prevention staff member. This program teaches them state-of-the-art strategies plus the tracking and surveillance methods identical to the hospital. So finally, we'll all start speaking the same language regarding C. diff. Hand hygiene, appropriate disinfection, early recognition and antibiotic stewardship are all part of the deal. And since we're your quality improvement organization, we provide the coaching and training at no charge. We're delighted to have Dr. Susan Levy, that many of you know, work with us as an expert consultant. Many of you know her formerly from Levendale and now as the president of the American Medical Directors Association, AMDA, which is recently renamed as the Society for Post-Acute and Long-Term Care Medicine. Dr. Levy has let us know that she is committed to getting prescribers, the nursing home leadership and nursing home staff, consultants, pharmacists, and families all on board to fight C. Diff. This includes having prescribers focus on antibiotic stewardship, which means when a resident does need an antibiotic, selecting one with a narrow spectrum for a short duration and avoiding those drugs with a higher risk of causing C. diff. She wants us all to commit to educating residents and families so they understand the risk of immediately asking for an antibiotic. For the nursing staff especially, keeping a high index of suspicion with any change in abdominal symptoms, since residents can get into serious trouble quickly. And Dr. Levy reiterates that the medical directors should be tracking cases alongside the facility's infection prevention nurse and providing good feedback to the staff. Next slide, please. So let's review. What are we trying to do here? We want to eliminate C. diff. Is that a whopper of a goal? Yes, it is. But think about this. If we even reduce it by 25%, that's a huge win for all of us. We also want to significantly reduce sepsis, and we're moving in the right direction. So I thank you to everyone who's on this call that's already taken those first steps. How will we know if we're on the right track for both sepsis and C. diff? We need to measure. It's the only way you know if you're making progress. We're here to help your team review the data and stay focused on opportunities for improvement. And what can you do to get started? Because I know you can't wait. You can join us and take a look at the next slide for some specific steps. Next slide. Sheila, would you like to review the next step?
Yes, I'll be happy to take this slide and talk through this. But before we do this, I just wanted to pause for a moment. We've given you a lot of information today, a lot of facts, a lot of information to take away and look at system approaches that you can take. And I just wanted to see if you all had any questions for Teresa or Candy at this point.
Ladies and gentlemen.
Yeah. Sorry, go ahead.
Ladies and gentlemen, if you have a question, please press star, then 1 on your touch-tone phone. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. So once again, if you have a question, please press star 1 on your phone now. I'm showing no questions at this time.
Okay. Well, just a few things that did jump out at me that I really would like to just kind of in summary share before we move into the next step. I think really what jumped out at me was all of the facts that Teresa and Candy both shared today, but one in particular took me down a path in my own mind, and that was one about the startling fact from literature about that sepsis appears to be the highest in African American males. There is also another statistic out there that I'm not sure if all of you all are aware of, but CMS did a study, it's probably been 5+ years ago now, but that wounds, pressure ulcers, or in the darker complected residents is often identified at a higher stage because of the difference in skin tone. So usually in darker complected residents, pressure ulcer may not be identified until at a stage 2 rather than at a stage 1, just because, again, the difficulty in that skin assessment. So in my mind, I went down this road that we have a male African-American resident who requires a pressure ulcer, or maybe he's even admitted with that pressure ulcer. It's a stage 2 pressure ulcer. It gets infected, so we now have a wound infection, which now is going to require antibiotic prescription. So now we have increased that resident's risk for sepsis, C Diff, a rehospitalization, and possibly death. So I think it just really struck me that it's so important that we as long-term care providers really assess all of our systems and begin to recognize how they're so integrated with each other and help our team to make those connections to ensure that we are really providing the total care for each individual resident, because ultimately that is who we are serving each and every day. We are there for our residents first and foremost. So VHCC wants to help you do that because it is a lot to do, and it's an effort every single minute of every single day. So how we can do this, and specifically with the connection around your systems to prevent and decrease sepsis and C Diff, is that, use your data. We are providing you data. We're currently providing you data for the Sepsis Project. That right now is going to the administrator, and as we learn of other team members within each of your facilities that want those reports, we're trying to distribute those, but at a minimum we try to send it to the administrator. If you haven't seen that data, please ask your administrator and our director of nursing if you're on the call and haven't seen this. And again, it's data we provide to you. Begin to enter your monthly data as part of the Sepsis Initiative, because again, we will take that and we will put that back into some analysis and some graphs for you, but we have to have it on a consistent monthly basis. We have been asking you to collect this sepsis data for March, April, and May. And if you have any sepsis data related questions, please reach out to Candy. She can answer those for you. As well as begin to implement or continue. I know many of you have already implemented and are using the Sepsis C100 tool, Sepsis 100 tool. So again, any questions around that, please reach out to Candy. And then we really ask that you integrate C Diff into your current infection prevention programs. As you've heard today, it definitely ties into sepsis prevention. So really a lot of this, Candy and Teresa will be working hand in glove, and we can make that very easy for you to do. So we have some links on your handouts that you can enter into your internet and get directly to our online forums to learn more about our C Diff project. You can also, again, reach out to Teresa for C Diff or even Candy. Again, they are partners in crime, so either one can definitely help you. And we are going to be doing another webinar around C Diff, and a lot of the same information that we presented today is going to be presented on June the 28th. So if you have colleagues that could not make today's call and you would really like for them to learn about this opportunity to prevent C Diff in your facility, please ask them to save this date and join us on June the 28th because you heard some of the costs from Teresa, and it's really approximately about $3,000 per C Diff episode. And as we know, our budgets are tight and we have to be physically smart these days and be good physical stewards as well. And our online community can also provide you these resources, and we have that web address here for you. So lots of ways to get to the resources. And then here's just another kind of picture of our online community. When you log into that, you'll see that you have some selections, and you can select Stopping Sepsis or our Nursing Home Improvement Network. And we've also added C Diff now to this as a selection as well. So encourage you to visit this website and join the community to get access to free tools and resources if you haven't already done so. So we have about 5 more minutes. Christine, do we want to do one more check for any questions?
Sure, and once again, if you have a question, please press *1 on your phone. We have no questions.
Okay. Well, I think we are at the end of our allotted time, so I want to thank you all for your commitment to be attentive and engaged, and I appreciate that. And feel free to reach out to any of us after this if you do think of questions or need assistance in being able to access any of these tools or resources that we shared. So have a good afternoon, and thank you so much.
Thank you, and thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now